I don't know if I should warn everybody, but I told Dr. Youngberg that since he's the last speaker, he doesn't have to stop at 12:15.
That's very dangerous.
That's what he told me. It was very dangerous. So, yeah. Anyway, we have been so blessed to have you here, and we'll let you share. And really and truly, if you go a little bit over, at least nobody else is waiting, right? They're just all waiting to go home.
Yeah. You can all leave anytime you want. It won't upset me at all. That's usually my excuse for going long. I say, hey, you can get up and leave anytime you want. I'm just going to keep going until the last one leaves. No, I won't do that too much today because I got places to go too. I got planes to catch and so forth. But it's been wonderful being with you this week, and thank you, Cindy, so much. This has been awesome. And thank you, Dr. Emerson. Man, great presentations. It's really neat. I miss so much working with a team of doctors like you, right? That was what's cool about working in Guam together. You know, we spent 8 years together on Guam, and just having other doctors like Dr. Horinucci and Dr. Supit and others that are really into lifestyle medicine. Working together in the same building, being able to, just share case studies together and talk about things and learn from each other. That's the way it should be. So even though I love being in my own private practice, I really miss being part of a group practice like that. And so that's what meetings like this are all about, is to kind of share information and learn from each other. And, we don't have to agree with each other on everything, but we learn from each other nevertheless. And I always tell people, this is the way I currently look at things. Next year, if you hear me talk, I might have some different perspectives. Why? Because I'm learning something every day, right? And this has been going on for 40 years for me, and that's okay. We can change our opinions on things little by little, sometimes a lot, very quickly, based on new information that is credible, that is rational, that makes sense. And so all the information that I'm sharing with you, hopefully it's just helping you kind of think about things and maybe rethink some things that you hadn't thought about before. And it might not be perfectly in line with what you currently believe or practice, but it causes you to think, hey, maybe I should incorporate this a little bit more, do a little bit more research so I can expand and improve upon what I'm currently doing in my practice, right? And that's what this is all about, is we don't have to have uniformity to have unity, right? And so let's jump into this topic here on insulin resistance, diabetes, and Alzheimer's, clinical implications, risk assessment, and intervention strategies. So, all right. I got to turn on my clicker. Okay, there we go. All right, so let's begin with, this is a really interesting study that was published in 2014 in Current Vascular Pharmacology that is looking at insulin resistance in the brain, possible therapeutic approaches. And I just want to go over a couple, basically establishing that insulin resistance is now understood to be one of the main drivers of impacting neuropathology. But it operates from many mechanisms, and that's why it's so important. This doesn't just affect one mechanism that might lead to cognitive decline. It impacts multiple mechanisms. So, all right, let's get into it. So we've already talked about the work of Dr. Suzanne de Lamont, who's a neuropathologist at Brown University, and she's published widely and extensively on this topic, as I mentioned previously, since the 1990s as a neuropathologist doing autopsy research on patients with Alzheimer's, showing that the brains of individuals with Alzheimer's, those cells, those neurons were very insulin resistant. So she started postulating. She's a very intelligent and insightful individual, and she started postulating all the ramifications of that that could impact her colleagues. She's a neuropathologist, right? So she's dealing at the end stage, at the very end. After it's over, what can we learn from this that we can then share with our colleagues so that they can make better decisions to prevent that neuropathology, right? So that's beautiful. I really have learned so much from her. And she basically, I'm going to share one of the presentations or studies that she did called Insulin Resistance and Neural Degeneration, Progress Towards the Development of New Therapeutics, right? We're always trying to figure out what is new. And the abstract was amazing. So let me just read to you sections of this abstract. She says, Alzheimer's disease should be regarded as a degenerative metabolic disease caused by brain insulin resistance and deficiency. Okay, so this it's really important to understand. Sometimes, I've been measuring insulin levels and the glucose tolerance test for patients ever since 1989. And actually, the reason it was really interesting to me. I had a geriatrician who was working with me. I was actually working with her at the Loma Linda Faculty Medical Group offices in Sun City, California. And she came up to me one day because she knew my great interest in insulin resistance and the work of Dr. James Anderson from the University of Kentucky. And she said, Wes, do you know that insulin resistance and resulting hyperinsulinemia is a major cause of breast cancer? I went, what? This is I think this was 1990 that she brought this to my attention. And I had no prior understanding that insulin resistance and hyperinsulinemia, or basically extra production of insulin, tried to compensate for that resistance. Just like what Dr. Emerson was saying, when your body's not perfusing nutrients and oxygen to the tissues very well, what's the kidneys try to do? It increases the blood pressure. So the body is trying to fix something by increasing the blood pressure, and then what do? Oh, we give a whole bunch of medications to lower the blood pressure without even impacting at all the cause of the problem. So we've actually potentially made the problem worse, haven't we? Because now we're decreasing the perfusion and we're limiting oxygenation and nutrients to the brain and other organ systems. So that's why we got to really be careful about, blood pressure's high, we'll just treat whatever way we can get that down, let's do that. No, how we impact risk factors makes all the difference. It's critical how we do things. So be careful on how you decide you're being successful in your clinical practice. Oh, I got my patient's blood pressure down from here to here, although we're doing good. A grade for me. Well, actually, you may actually be increasing that person's risk for dementia later on and other potential problems. So how we do things is so critical. That's why the whole field of what we're celebrating this weekend of lifestyle medicine and how to do things is so critical. Yes, we want to have optimal blood pressures, but how we do that is very, very important. Because if we don't understand that, we may be completely missing the point. So normally we think about high insulin levels being bad, and it's true. High insulin levels are bad, but the body is trying to fix something. So when the body makes more insulin, the goal isn't just driving insulin back down. The goal is fixing the resistance so that the pancreas doesn't have to make that much insulin. Because if you maintain the insulin resistance and then you somehow lower the insulin levels, that's actually really bad for the brain, because that means that the brain is not getting the nutrients that it needs, or the organ systems and the cells are not getting the nutrients they need, the glucose in this case. So anything that impairs blood glucose flow from the blood into the brain or into the cells is going to be bad. In fact, that's the whole basis for the fluorodeoxyglucose PET scan. It's basically, as Dr. Emerson pointed out yesterday, It's basically, or Friday, it's basically you're evaluating how good is the metabolism of glucose from the blood into the brain. How well is the brain being nourished in all of its centers by glucose? And when that doesn't happen, it's like strangling. It's basically starving the brain, and you're literally destroying brain cells because they're not getting enough glucose, the primary fuel source for the brain, for neurons. So, hey, I got a good answer for that. Just eat a Snickers bar every couple hours. I mean, that would be one quote, mechanistic, semi-logical way to respond. And that's what a lot of people do. Oh, just eat more often. Just eat healthy food more often. Eat some kind of carbohydrates more often, and you're constantly getting more glucose into the bloodstream and hopefully getting more into the blood. Is that going to work? On the surface, it works temporarily, but it's actually making the problem worse later on. And so those of us, and I know that we have individuals in this room that, like me, have a tendency to reactive hypoglycemia. And the answer medically, oftentimes, if you finally come to the realization that it is a real medical condition, right, that, you just eat more often. That's the answer. That's kind of the easy answer. Just eat more often, okay? But that's not the solution. The solution is to address the problem more upstream, where the problem really is. And we're going to be talking all about that. In the handout that entitled the interpretation of the 2-hour glucose tolerance test goes into the steps on how to fix that in detail. So the point here is that if you're not producing enough insulin, that's really bad for the brain. But if your body is attempting to fix a problem with not getting the glucose into the brain and is making more insulin to solve that problem, that extra insulin is also bad for the brain. So it's good for the brain and it's bad for the brain. So how do we figure this out? So the key is fixing the fundamental factors so that the pancreas only has to produce just enough insulin, the right amount of insulin, to control the blood sugars effectively all day long. Not just before meals, but also right after meals, which is the most sensitive time, and so on. So if you can get to the point where you have balance between glucose and insulin all the time, now you have perfect perfusion or metabolism of glucose in the brain. And through the intermittent fasting principle, through the idea of there's something that we've learned by reading books like Ministry of Healing, and information has been out there a long time before there was any good studies to support that, way before, talking about it would be good to eat every 2 to 3 hours. No, that's not what it says. It says it'd be good, it'd be ideal to basically limit our food intake to maybe 2 or 3 times a day with at least 4 hours, maybe 5 hours between meals. That's not legalism. That's just guidance that makes a lot of sense. But for that to work, you have to eat the right food. Because if you're not eating a healthy breakfast and you start getting hypoglycemic 2 hours later, it's actually bad for you to wait 4 to 5 hours to eat again, because you've already made the mistake. It's like my problem with the French toast super stack. If you make a mistake, if you're not doing things right prior, you're already set up to have all kinds of problems. So if you don't eat a healthy breakfast, if you don't get a good night's sleep, if you don't get some exercise after that meal, you're much more likely to have that reactive hypoglycemia at some level. There's a continuum in all of us. And that drop in blood sugar is bad for the brain. So the key is to be aware of the issues and preempt it from happening in the first place. And so, in other words, I tell my patients, if you have low blood sugars, do something about it. Okay, but the answer isn't, take a lot of sugar or drink, my doctor says if my blood sugar gets low, then I need to drink a soda real quick. Well, that's, one possible solution. That will bring your blood sugars up, okay, but it's not the best option, right? The idea is to eat something healthy, like maybe eat a few slices of apple and maybe some nuts, right? So you get some protein, some fat, and some sugar, but it's healthy to get your blood sugars back up. Now, obviously, there's a continuum here. If you're like, going into diabetic coma with, your blood sugars are crashing and you're going to end up in the ER, then I'm not going to say don't drink that soda. So you got to do something to get yourself back up to so that you're not ending up in the hospital or dead. This reminds me in terms of the need for insulin and the need to manage blood sugars properly. Back in the mid-'80s, when I was at Loma Linda, one of my roommates, I had 8 roommates, and one of their good friends was I think he was a freshman medical student who lived in another home with had about 8 medical students in it, and he had type 1 diabetes. Well, one Friday night, everybody was getting ready to go to Vespers, and they asked, "Hey, you want to come?" He says, "I'm not really feeling very good. I think I'll just stay home tonight." And he did, and when they got back from Vespers, he was in bed, and lights were out, so they just got up the next morning to get ready to go to church, and they went to wake up their friend, and he was dead. So apparently he'd taken insulin and not eaten properly or something, and caused severe hypoglycemia, and he was dead. Okay, so insulin is critical for life, but you got to manage it. And so the point here is that if you don't have enough insulin, it's really bad for the brain. We don't normally think about that unless somebody's a type 1 diabetic. But the reality is that the body is trying to fix the problem by making more insulin to overcome the resistance. And unless we understand that, we're not going to come up with the right solution. The insulin is one of the hormones that is critical to the trophic health of the brain. If you're not producing enough insulin to do the job to get the glucose into the brain, okay, you are actually causing an endocrine disorder that's leading to neurodegeneration. And so that's why Dr. Bredesen makes a big deal he has in his RECODE reports. It's like a 60-page report that has all the different categories of factors that promote Alzheimer's, or he calls it the different types of Alzheimer's. And one of them is the trophic factors. Trophic factors are all the hormones or the things that can stimulate the growth of the hippocampus. Okay, the growth of neurons, the repair of neurons. And there's many hormones that do that, right? And insulin is one of the key growth factors. That's why you have insulin growth factor 1, etc. And so if you're not producing enough insulin to fix the underlying problem, you're going to have problems with cognitive decline over time. Okay? Just like if you don't have enough testosterone, you're going to have problems. If you don't have enough estrogen as women, you're going to have problems. And so all these, and there's all kinds of research on this. We don't have time to get into that specifically. We're focusing more on insulin right now. If the insulin is dysregulated, you know that cortisol at some point is going to be dysregulated as well, and that messes with the brain. That leads to neurodegeneration when high, but it also leads to neurodegeneration when low. You want the trophic factors to be balanced. Not too little, not too much. All right. So, and we'll get into that more as we move forward. So, so we're dealing with brain insulin resistance and deficiency overlapping with molecular, biochemical, pathophysiologic, and metabolic dysfunctions in diabetes, non-fatty or non-alcoholic fatty liver disease, and metabolic syndrome. Although most of the diagnostic and therapeutic approaches over the past several decades have focused on amyloid beta, right? So essentially, almost all research is funneled into addressing beta amyloid in the brain. And in fact, there's all kind. If you've looked into this at all scientifically, there's a huge political challenge in the world of medicine and neurology, because the people that control the research dollars at the NIH, et cetera, they have bought into the everything is about beta amyloid. Everything is about beta amyloid, when in fact, that is only one of the mechanisms involved in neurodegeneration. And Dr. Suzanne de Lamont is making a key point here, is that the focus has been on beta amyloid. You almost could not get a study approved unless it was addressing beta amyloid. That's been a very big pet peeve of scientists all around the country, because they could not get their study approved unless they were doing what the top elite researchers that controlled the kitty at the NIH addressed. So basically, in beta amyloid issues and the aberrant phosphorylated tau issues, like we discussed on Friday, okay, those definitely can be caused by brain insulin resistance. But her point is that insulin resistance causes many, many more other problems as well. So we don't just want to focus on beta amyloid. So including white matter atrophy and loss of myelinated fibrils and leukocyte, non-beta, amyloid beta 42, microvascular disease, etc. So bottom line is you can get this neuroinflammation, and these are general neurodegenerative issues that go beyond and they're separate in many respects to Alzheimer's. Yes, inflammation can promote Alzheimer's, but it can promote any other forms of dementia as well, and neurodegeneration. That's why the tests that we talked about at the first lecture include not only the phosphorylated tau-217, okay, but also the neurofilament light that looks at neurodegeneration, okay, and the glial fibrillary acidic protein that looks at inflammatory changes in the brain. Which is different. It can contribute to Alzheimer's, but it can also contribute to other problems not associated with tau or beta amyloid. Okay, so basically, it addresses, there's many neurodegenerative mechanisms that are not readily accounted by the beta amyloid theory, okay, but could be explained by insulin signaling, like we alluded to earlier, etc. So she's basically setting the stage that we got to have a more multifaceted approach. Whoa. Oh, here we go. Okay. That I can read. Okay. So, all right. It's like we're redacting this study because nobody wants you to know about it. Okay, but now we have. So here we go. So here the researcher is saying that there's functional impairments in brain insulin and insulin-like growth factor signaling, okay, and that are the major drivers of Alzheimer's disease in this neurodegenerative cascade. But Alzheimer's disease-associated insulin deficient and insulin-resistant states mimic those of diabetes and affect cell types, all cell types in the brain, all cell types. Okay, so besides accounting for the abundant amyloid beta, hyperphosphorylation of tau, etc., insulin pathway dysfunctions cause cortical atrophy, loss of synaptic plasticity, white matter degeneration, astrocyte and microglial neuroinflammation, oxidative stress, you heard discussed earlier, deficits in energy metabolism, mitochondrial dysfunction, and microvascular disease. That's why we got to figure out this issue with insulin resistance and practical clinical strategies for assessment and intervention. So the same neurological processes have been linked to cognitive impairment in type 2 diabetes, Parkinson's, and vascular dementia. She goes on to say that the main conclusion here, this is Dr. Suzanne de Lamont, saying we have now arrived to the point where it's time to address the long-term deficits in trophic factors. In other words, you'll be seeing here that if you actually measure insulin production, not only fasting, but more importantly, at 1 and 2 hours after a glucose load, you're actually seeing how much trophic loss there is, or beta cell damage and atrophy is in that patient, which allows you to accurately predict how easily it is for that person to reverse their type 2 diabetes, but also how potentially damaging every day is to hippocampal growth or regeneration. Okay, so that's why this is really, really important. So then she goes on to say that there is great need for a multi-pronged rather than single-pronged therapeutic targeting to mediate Alzheimer's disease. So stop looking for the magic bullet, either in pharmaceuticals or even in lifestyle medicine. There is not one thing that's going to fix this. Just as I've been pointing out, you have to have a very aggressive, multifactorial approach, or this is not going to work. And that's why I wanted to read that abstract from Dr. Suzanne de Lamont. Now, here's another study. Some people say, it's always been controversial, the whole topic of hypoglycemia. For those of you that have been in practice for many years know that, back in the 70s, it was kind of a popular theory, it was said, that hypoglycemia was a problem. And many doctors basically completely dismissed the idea that hypoglycemia was a real thing. I remember in practice, typically I spent the first 30 years or first 25 years of my professional career working in group practices. And I just saw that, where many of my colleagues, they were like, they just kind of, their eyes would glaze over when we talked about hypoglycemia. Okay. Real quick, I had one family physician that kind of changed her mind on this. One day she was talking to a patient who kept complaining about hypoglycemia. and so she was trying to nicely explain to her that's really not a thing. And so then one day, this patient is driving back from Riverside towards Temecula, so coming south down the 15 freeway. And she told me later that she was driving, and all of a sudden she went tunnel vision. And she said, I didn't know what was going on, but the sheriff later came up to me, and she said, and asked me if I'd been drinking. And she goes like, no. And so she was kind of a little out of sorts, and she said, no, I wasn't drinking. And he immediately pulled out a little packet of like what marathoners, eat, little goo, which is just glucose that you just suck on it so that you keep your blood sugars up, and basically put it in my mouth. And since I was like scared, and I was kind of put my hands up, and says, no. That she thought that this police officer was actually kind of setting her up, making it look like she was under the influence. Well, she was under the influence, but she didn't realize it, right? And so he put this goo in her mouth, and within seconds and minutes, she said, all of a sudden her brain came alive again, and the tunnel vision just disappeared. And she looked around, and the traffic was backed up onto 15, and there was police cars there, and she said the ambulance showed up about 20 minutes later, checked her blood sugar and said, oh no, your blood sugar is perfect. What did that prove? Right? Nothing. It's like, because what? The problem wasn't with her blood sugar right then. Her brain was working fine at that point. The problem was 30 minutes before, right? And so what had happened is she'd gone hypoglycemic significant, and her brain started shutting down compartments. It's like a blackout in a big city. You see that? Where sections of the city are just going dark. Boom, 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 boom. And there might be one little section of that city that still has power. Usually it's the hospital and the Capitol building. They still get the power. Everybody else is shut down. That's what's happening to the brain during hypoglycemia. Patients tell me all the time that when they do the 4-hour test, and I realize this is a hassle. You got to sell this to your patients, or else they're not going to do it, right? And 99% of my patients do it. And I tell them it's a real hassle. I tell them you got to be at the lab all morning, and you got to take the time to be there. They're going to be drawing your blood 6 times. 6 times they're going to be drawing your blood. Fasting, half hour, 1 hour, 2, 3, 4. Okay, and so I basically tell them all the problems with it and say, I tell them I've done it like a dozen times. It's one of the best things you could do, because otherwise you're not going to know if you have problems with insulin dysregulation, cortisol dysregulation, and potentially reactive hypoglycemia. If you just want to figure out insulin resistance at its core and pre-diabetic tendencies, etc., hyperglycemia, the first 2 hours is all you need. Okay, but if you want to know the persistence of that, if it's present or not, how persistent it is, and you want to know if you have a reactive hypoglycemia, most people don't go hypoglycemic till the 3rd hour, sometimes the 4th hour, sometimes the 1st hour. Okay, so this lady, she went hypoglycemic, and she didn't realize this, but she was basically using all 4 lanes of the freeway. And she just naturally slowed down because she didn't know what she was doing. And so she was probably going about 30 miles an hour doing this. Okay, so obviously all the traffic just instantly backed off of her. They're going like, what is with this lady? It's like 10:30 in the morning. Has she been drinking all night long and just now getting home? What is going on? And so obviously CHP, the California Highway Patrol, was right on there, got there. And what happened is that she went back and forth multiple times, then clipped the median guardrail, and that spun her all the way back around to the other side of the freeway, where she ended up facing against traffic on the other side of the freeway. Fortunately, off the freeway, okay, but now there she was. And so now she's super embarrassed, And the cops, fortunately the cop knew what was going on, right? Okay, he knew better than a lot of doctors did about that. And so he fixed the problem and got the ambulance, got her. So she's at Inland Empire Hospital there in Temecula, and sitting in the ER. and she said, the ER doctor came in, was kind of, checking her out. She was fine at this point. And, everything came back normal on all the labs that they did at the ER, like happens so frequently, because, you're not going to find anything in the ER unless you're really bad off at that point, right? So she said to her ER doctor, I'm so embarrassed. He says, this has probably never happened before. And he turned to me and said, are you kidding me? There's somebody in two rooms next to you that the same thing happened on the 215 freeway just an hour ago. Now, I don't know how often that happens. That's the only 2 times I've ever heard about happening on the freeway. But I bet you it happens a lot, and people don't realize it. People have accidents and maybe die, the cause of which is simply because you went horribly hypoglycemic. Okay, so did you know that you can get a DUI because of hypoglycemia? If you took insulin in the morning and you didn't properly manage your meal, Okay, and that insulin drives your sugar really low and you get into an accident, you're driving under the influence. Legally. Did you know that? Okay, so it seems like kind of harsh penalty, but that's what it is if you follow the law. And so that's why when we worked with our diabetics over the years, we would say it's worse to be over-medicated than it is to be under-medicated. Far, far worse. Because, it used to be back in the 70s and 80s and even into the 90s, endocrinologists and diabetologists were saying, you're not really getting good control unless you have hypoglycemia at least once a week. Right? Okay. And maybe some of you remember that mantra. And I understand the principle, right? In other words, you got to work at controlling your blood sugars, but in order to control your blood sugars, in order to get that high down to a reasonable level, that means you're increasing the risk of the lows when you're doing the management from an unnatural perspective. In other words, when you're medicating with insulin or something like that, you are now forcing the situation against the body's natural inclination, right? That's what you're doing, okay? And so that's why we want to use as much lifestyle medicine as possible to limit the need for the medication, not because we're against the medication, but because it works a lot better, okay? And we're saying, allow your blood sugars to go higher while you're intervening on this process, because the alternative to that is really bad for you. If you let your blood sugars get too low because you're hesitant to adjust your insulin dose or adjust your dose of your insulin-promoting medications, you're basically in real trouble potentially. So that's why in our Diabetes Undone programs, in any diabetic program that we run, we always put a disclaimer about, you must be monitoring your blood sugars regularly if you're going to do this program. Okay? If you're going to change your lifestyle in any way that's better for you, you got to be monitoring your blood sugars, because if you don't, invariably you're going to end up with lower blood sugars. You're going to be over-medicated in that sense, and that's far worse for you than being way under-medicated. Okay. And why? Because it literally damages the brain, among other organs, right? So in other words, this is not just somebody's let me finish the story. So the question is why, what was going on? So she was referred to me by her family physician, okay, to treat hypoglycemia. I go like, wow, I don't see that very often, right? So I had an interesting talk with the family physician about that. And so I put her on a program, much like we promote in Diabetes Undone, basically looking at optimal diet, high fiber, intermittent fasting. But I was careful to address that with her. You know why? Because when she showed up with me the first time, she had a big old bottle with her, and it wasn't full of water. Guess what it was full of? Orange juice. And she was sipping on that every 2 to 3 minutes. She was freaked out about hypoglycemia. Why? Because she was experiencing it all the time. Her blood sugars would just crash. And so I ran a glucose tolerance test on her, a 4-hour. She had a fasting insulin of 60. 60. Okay, now if you've ever checked out fasting insulins, basically top preventive endocrinologists back in the day would say that your goal is to have a fasting insulin less than 10. Ideally, you want it to be less than 5. That's ideally. But you have to be careful how you interpret insulin levels, because you only can interpret that properly relative to what the blood sugar is at that time. So if you have a low insulin level of what would be considered an ideal fasting insulin level of less than 5, but your fasting blood sugar is 110 or 120, that's really bad news. That means you have beta cell atrophy that's way over 50%, and you're not able to produce enough insulin, even at a fasting state, to try to control your blood sugar. That's bad. That's bad. So that's predictive, clinically, of a more rapid decline into full-blown diabetes and actually into a form of adult onset, more autoimmune diabetes. That suggests that your pancreas is being destroyed very rapidly. Okay, so always in this, the handout that I have, the 11-page handout, goes over this in detail. I'll take questions at the end, okay? So the bottom line is that you have to compare insulin to the current blood sugar at the same time, or else it's really, you don't know. It could be really good or it could be really bad. Okay, so hypoglycemia is a very real problem that impairs brain function. So let's just jump into looking at basically how hyperinsulinemia promotes Alzheimer's and issues of pancreatic fatigue, inadequate insulin production, causing cellular hypoglycemia and neuronal hypometabolism, promoting atrophy. Okay, so what are the two pillars, okay, of pathophysiology in diabetes and therefore in type 3 diabetes, which is insulin resistance of the brain? So first of all, we have on the one hand the resistance that develops to insulin and the concomitant need for the pancreas to try to fix that by just producing more insulin. And we call that the good news and the bad news. And so when I do a glucose tolerance test on patients, I say, well, there's good news and bad news. The good news is you're producing lots of insulin. The bad news is that you're actually not able to produce enough insulin anymore to control your blood sugars. So even though you're producing 5 to 10 times more insulin than you should actually have to be producing, so you are producing a lot of insulin, but we now know that your insulin producing capacity, that is the ability of your pancreas to make insulin, has been maxed out at a point where you still have high blood sugars, which means you have beta cell damage, significant beta cell atrophy. But which can be improved over time, by the way, but only if we take the stress off the pancreas and remove the factors that are damaging the pancreas. And we'll get to that right away. Okay, so the American College of Lifestyle Medicine actually has entire courses now, CME courses for doctors and health professionals where you get all these presentations on how you actually reverse insulin resistance and reverse prediabetes and diabetes. I actually helped develop the very first one that was done some years ago. I did not have time to be involved in this more recent one that's available, but it's really good. It's the first organization that actually put together a entire CME certificate course on reversing type 2 diabetes and insulin resistance. So that's available at the American College of Lifestyle Medicine website. You've already heard my discussion of how I first learned about this from Dr. James Anderson in 1985, and he'd been doing it for 15 years already. So this is not new information. I don't have time to tell you the story. It's an awesome story, but if you haven't seen Supersize Me, watch it. It's really, really interesting. He actually interviewed bariatric surgeons to show how you could actually reverse diabetes with bariatric surgery. Now, am I promoting bariatric surgery to reverse type 2 diabetes? There's a lot easier ways to do this, okay, that don't create a major dysfunction over time. What's the main problem with many forms of bariatric surgery, especially historically, is that it creates chronic malnutrition syndromes. That's why bariatric surgeons in follow-up, they do more blood tests than I do, and I do a lot of blood testing. They check every mineral, every vitamin. Why? Because bariatric surgery oftentimes dramatically alters your ability, right, to take on nutrients. Okay, so there are cases, I'm sure, where that's a reasonable thing to do, but for most of us, there's better answers to it, and that's what we're addressing. Now, the reason I wanted to bring this up real quick is that in 1994, it was one of the first medical studies that showed that diabetes could be reversed. That was well accepted by the population. Dr. James Anderson had been publishing studies for years already, for over 20 years already, but had been largely ignored by his colleagues in the endocrine field. Okay, but this study made national headlines. I even heard about it on the radio driving to work one day. Wow, oh, this is interesting. Bariatric surgery, after 1 year, 77% of diabetics reversed their diabetes in 1 year. Wow, that's awesome. Okay, now, there's all kinds of things, and there's new things that basically taking the place of bariatric surgery. Anybody heard of the GLP-1 and receptor agonist medicines? Okay, now we don't have time to get into that, and obviously that's very controversial. You can't open up any medical journal or Medscape, for doctors without being inundated with all kinds of studies strongly promoting the benefits of GLP-1 receptor agonists, some like glutamide and the Ozempic, Wegovy, etc. Now, so I'm not going to get into all that controversy right now. I just want to make a point, okay, that, we talked about the two pillars of the two most important health commandments yesterday. That Dr. Sid Baker from Yale University Medical School championed. He says, if you're going to improve health, you got to do two things. You got to optimize the things that nourish and heal the body, which are nutrients in the broadest sense of the term, and you got to get rid of the interfering elements, which are the toxins. If you do those two things, everything that we're talking about is in those two categories in some way. Okay, and so what's the problem with the GLP-1 receptor agonist is that in theory, they're potentially impacting the decrease of toxicity. Why? Because people don't want to eat very much. So really what's going on, the way I look at it, it's actually an antihedonic. You don't hear that term very often, right? But anhedonia is the inability to feel pleasure. Okay, basically these medications actually dramatically decrease the pleasure of eating. You talk to patients who says, I just don't feel like eating anymore. I don't, you can put my favorite dessert out there and like, well, yeah, just I don't get any pleasure from that, so why should I eat it? Okay, and of course, there's a lot more to this that we don't have time to get into. But this is a critical problem. So maybe you're eating less of the bad things, and of course, that's going to be good for you in that respect. But how you're doing it and the other side effects associated with how you're doing it, that's really the big issue you got to pay attention to. And one of the biggest, broadest principles that I'm concerned about is that if you're just simply eating less, but pretty much the same things that you did eat, and because you don't really get pleasure, as much pleasure at least, from eating as you used to, and when you do eat, you basically get full too easy and you feel full longer because the food is not moving through your digestive tract very, very fast because your vagus nerve is being partially paralyzed, right? Okay, and so you have problems moving food, and so you're getting all this fermentation and putrefaction going on in your gut. That can't be good. Now you're actually increasing toxins dramatically. And again, this is not the topic for today, but the point is there's a lot of concerns. Do people reverse their diabetes when they do that? Yes. Yes, they do, just like if you did bariatric surgery, but there's a cost. Okay, and we're just now starting to see that cost with all kinds of lawsuits, etc., with people have been very harmed. I did a major series in Dubai last year, and a lady came up to me, and she was actually very upset, very dissatisfied. She wasn't getting all the answers she wanted, and she was very nervous. She was very well-to-do, and she says, I've been always trying to do what's best for my health, okay, and I had pre-diabetes, and my doctor says you got to do, the first thing she said to me, she said two things to me that we're not going to get into details. So number one, the doctor said, you got to get the COVID vaccine. She says, that within a week, I had diabetes. It went from early pre-diabetes to just dramatically. And so in her case, I'm not saying this happens to everybody, it doesn't, for sure, but it actually dramatically, basically it damaged her pancreas is what happened. Okay, so, and there's all kinds of studies documenting that, by the way. That's just not my theory. I could prove that to you. So it's a real thing. And then, so she was really upset about that. And then when she had diabetes, what's the first thing many doctors will recommend now if you have diabetes? No, not even that. What's the most powerful thing? What's the big thing right now? That's what we're talking about. It's GLP-1s. Okay, and so she was talked into going on Ozempic or one of those, and she said my blood sugar. I was checking my blood sugars with a continuous monitor, because she was super anxious about it, so she was really paying attention. And she said, after taking that that injection, my blood sugar skyrocketed. Now, that's not the normal response. Normally, it's going to go down. Why? Because you're not eating much. Okay, but blood sugars aren't all about what you eat. They're about many other things going on, including if you're damaging your pancreas, your blood sugars are going to go up, even if you eat healthy food. Okay, if you're stressed out about something, your blood sugars can go up 300 points. I've seen it many times in my patients, just because they're stressed about something that they thought happened but didn't. Again, another topic. So the point is that when you're on that approach and you don't feel like eating anymore, are you actually getting enough nutrition? And the simple answer is absolutely not. You're missing out on one of the two most important pillars of health and healing, so of getting enough nutrients. And so if you take an anti-hedonic, that basically means you no longer enjoy eating junk food, you no longer really enjoy eating anything, but you just eat enough just to stay alive, you're going to be malnourished. There's no possible way that you're going to be eating 5 or 6 servings of non-starchy vegetables. In fact, non-starchy vegetables is the last thing on the list, because that's not going to digest as easy. They're going to eat something simple, something refined that they can get in pretty quickly. So be aware of that concept. That's a really critical concept here. And so just because something works really well, you got to always ask the question, like, if like I said last night, if moderate drinking is really good for heart disease, like many epidemiologic studies suggest, what is missing in that discussion? Okay, if it's true that is good for you, which it's not, by the way, but let's just say it is true, okay, we have to ask, well, what's the downside? And the downside is cancer, dementia, etc. Okay, so you have to have complete disclosure as to the pros and the cons of what we're doing, right? All right. So Dr. David Eddy, I mentioned this earlier. Dr. David Eddy is a MD PhD. His PhD was in mathematics. He's a brilliant mind, Stanford trained, and he in 2009 did what I call one of the first AI studies, where he did a computer simulation of thousands of patients by all their medical records, and he said, okay, we're gonna just completely resolve one risk factor and run that computer simulated study for 60 years, from age 20 to age 80, and see what impact did fully controlling that one risk factor alone have on preventing heart attacks. Okay, and so here, this is what his conclusion was. Insulin resistance is likely the most important single cause of coronary artery disease. A better understanding of its pathogenesis and how it might be prevented or cured could have a profound effect on cardiovascular disease. This was in 2009. He was actually hired by Kaiser to set up their algorithms so that they could decide what the most efficient way of of assessment and treatment is. And so if you're a Kaiser physician, well, you would know better than I, but I see quite a few Kaiser patients who come into me for out-of-the-box treatment, right? Because at Kaiser, which is a great system, but they only operate within the box. If it's not on the computer, it doesn't really exist. It's not on the formulary. So anything that's outside of that box, you got to go to somebody else. And so they're really good at what they do, but they don't think outside the box at all. And they're not allowed to, because if it's not on the system, the doctors can't actually prescribe it. Okay, I had a physician from Kaiser come to see me as a patient, and he had prediabetes. And so I said, well, hey, let's see, you're a doctor at Kaiser, that I'm sure that you could get many of these blood tests done at Kaiser. So I recommended that he do a glucose tolerance test, a 4-hour test at Kaiser with insulin levels. And he went to the lab, and they said, absolutely not. I'd be like, what? I said, you're the doctor at Kaiser, and the lab says, no, we're not doing it, because it's not in the system. Just can't do it. And so he had to do all that assessment outside of the system. So that's why I said last night, don't just only do labs that your doctor will run for you, right? And if you are not allowed to run a lab because of a contract you have with that insurance company, et cetera, and that's going to be happening more and more now, right? Okay, you want to figure out a way to allow that patient to order their own labs. And you can do that on ultralabtest.com really easily. They can order anything. We help patients order on ultralabtest.com. It's through Quest. Okay, and it's like 85% discount on all labs, and they can get any lab they want. Any lab that you can order through the national labs, they can get if they want it. So be aware of that. Okay, so Dr. David Eddy is saying here, see, based on this AI algorithm, we discovered that this is way more important than cholesterol, more important than any of the other known established risk factors for myocardial infarction. So he's basically saying that's really good for heart disease, and I'm saying the same principle applies to many, many other things: cancer prevention, cancer management, Alzheimer's, and so forth. So, and this was basically what they found. The 60-year simulated study from age 20 to 80 basically found that insulin resistance fixed for that 60-year period prevented 42% of all heart attacks. Far better than any of the other strategies. So, all right. So basically, when we're looking at assessing pancreatic function, we need to understand the stages of burnout, where at first the pancreas just is making a lot more insulin. It's just working overtime. And it can do that because it's healthy, it's robust, it has resiliency, it has reserve capacity. But little by little, all the things that are in our lives that can destroy beta cells, little by little, those beta cells are being destroyed, and we want to understand what those things are, because then it goes to fatigue, overwork, and ultimately it is failing. So the key to understand, and this is very important, that even before prediabetes is diagnosed, it is common that pancreatic function and insulin-producing ability or potential is already compromised by over 50%. So I believe that there's similar concept here with hippocampal atrophy, is that even before people notice that there's a real problem with cognition, is that if we had technology sensitive enough, that's why we want to get the number, the volumetric number, we can actually see that there is very early hippocampal atrophy. Remember on the study on sleep, even young adults, healthy young adults, college-age adults, are already showing signs of hippocampal atrophy when it's measured with sensitive indicators. Okay, so those are the things that we want to know, if possible, and how to prevent them. Dr. Ralph DeFranzo, professor of medicine at University of Texas Health Science Center, he noted that pre-diabetics in the upper third of that category, okay, where you have your fasting blood sugars maybe 110, okay, that's the kind of more an advanced pre-diabetic condition. Your 1 hour glucose is high, like above 200. 1-hour glucose is not diagnostic. And so that's why it's not officially part of the 2-hour glucose tolerance test. You just get a fasting in the 2-hour. A big mistake, because the 1 hour is by far the most insightful, the most sensitive test. And I had many patients who are perfect at fasting, perfect at 2 hours, 1 hour blood sugar is above 200. That is very problematic. That is showing early problems with pancreatic function, number one, their ability, their beta cell reserve, okay, and of course, insulin resistance. And then diagnostically, you have the 2 hour. If it's above 140 or 139, that is officially prediabetes. That's the most likely way to diagnose prediabetes at 2 hours. But if you're up, at 160 or above, that is definitively advanced prediabetes, strongly related to cognitive decline. So the point with Dr. DeFranza is saying is that at that point, you're near maximally insulin resistance, but more importantly, you've already lost 70 to 80% of your beta cell pancreatic function, which can be gradually regained, just like hippocampal volume can be gradually regained, but we want to catch this early so we prevent all that loss over the years, right? That's the purpose of the handout that I gave you. Okay, I'm just going to blow through this real quick. This is an interesting study done at the Mayo Clinic. Dr. Montori and colleagues, they evaluated 16 guidelines and 328 journal articles, 11 meta-analyses that were published between 2009 and 2014. And they basically, this was published in 2016 in the journal Circulation. And so here's their main point. Okay, so overall, they found no significant benefit of tight glucose control for the risk of kidney dialysis, kidney transplant, renal death, blindness, or neuropathy, on and on. So nevertheless, they said 77% to 100% of published statements and 95% of the guidelines unequivocally endorse benefit. Now, I know this has changed recently. The point is that just because you have the majority of medical societies endorsing a certain guideline doesn't mean they're right. And this was pointed out by the Mayo Clinic researchers. Didn't get a lot of press, didn't make a lot of happy doctors, because they're saying, what are you telling me that what I've been telling my patients for the last 20 years is wrong? That's essentially what they're telling them. And so we got to be really careful who we believe here. We got to use critical thinking. That's one of the themes here of this weekend. And so they went on to talk about this. So the bottom line, they said the Accord study in 2008 actually found that tight glycemic control actually increased all-cause mortality by 26% and cardiovascular mortality by 43%. I remember talking to Dr. Brenniger about this concept years ago, many, many years ago. He was the diabetologist in charge of the Loma Linda University Diabetes Treatment Center, and great guy. And I'd been reading these studies that had been multi-university group studies that had been published back in the late 70s, showing that those individuals that went on glypinase or any of those insulin-producing medications, they actually had, on average, a 2.5 increased risk, 2.5-fold, 2.5 times increased risk of premature mortality than the control group. And at the time I go like, what? Like this is like the biggest study ever done on the topic, and everybody still is prescribing the same medication. That was even part of our protocol at our clinic. And so I brought that up, and he went, well, there was a lot of diabetologists that wrote in letters to the editor arguing with the study. I go like, well, okay, yeah. So everybody has a right to their opinion, but what about the data? What about the fact that this the biggest randomized study ever done on the topic showed that there was a 2.5-fold increased risk in premature mortality? Okay, and it has, so again, guidelines, be careful what you believe. All right, so bottom line is that the exclusive focus on blood sugar control, that is, let's just get the blood sugar under control by whatever means possible, right? That clinical reality that has been a focus of even current studies for prevention of complications in patients with type 2 diabetes has essentially shut down other avenues of research, just like the beta amyloid issue. It's worth pursuing improving the health of people with diabetes exclusively. Okay, is it worth pursuing improving the health of people with diabetes exclusively with interventions that reduce sugars? That's essentially, clinically, what happens in medicine is that we just look at ways to lower the blood sugars, because if we only have 10 minutes or 15 minutes with the patient, we're going like, you got to make sure you're on this medicine or the second or third medicine, or maybe the GLP-1. That's so much easier than just adding more diabetic medicine because it works so well. But again, we're not paying attention to the big picture there. So, they say at the Mayo Clinic, should we be expanding our approach, looking for new ways to prevent diabetes complications beyond the control of blood sugars? This is really critical. I tell people, they say, I'm doing everything right, my blood sugar is still high. I says, you're getting better. They go, no, I just told you my blood sugar is still high. I said, I understand, but diabetes, or the health is not all about blood sugars. We want to figure out, if possible, how to lower blood sugars in a diabetic, but if there's a problem with blood sugars, the most important thing to do is first fix the fundamentals, even if it doesn't budge the blood sugars. In a few cases, that's true. I'd rather have high blood sugars and be on an optimal diet, be on an optimal exercise program, doing all the things that we're talking about, than to have perfect blood sugars, but have this false sense of security thinking, oh, wow, look at me. My blood sugars are perfect, and I don't even have to worry about my diet and exercise like my friends here who have high blood sugars. Right? You got to be careful with how you think about this. So this really got me when I read this some years ago, over 10 years ago. I said, we just could not find any line of work at the clinical level with patients that is pursuing an alternative. And I felt like calling up and say, hey, did you hear about? And so, but that was their experience, and they did the research. They just couldn't find it. And these are the top clinics in the world, right? And it's really sad. It's really sad. So there's all kinds of medications that can increase the risk of diabetes. And so we, including statins, according to the US FDA in 2012, they actually put warning information about increasing risk of diabetes. Why? Because statins increase insulin resistance, which is bizarre. We just learned from Dr. David Eddy that insulin resistance is by far the biggest risk factor for heart disease. And yes, statins lower cholesterol better than anything. Okay, but as Dr. Emerson pointed out, that's really not the point. That's not what lowers the risk that much. Statins, even if you look at their research, only lowers the absolute risk of heart disease if you've had a heart attack by 1%. Okay, so you got to look at better alternatives, which that's why addressing what Dr. Emerson said this morning is far more important in minimizing oxidation of cholesterol. So we have. Let's take a look at factors causing damage and destruction of beta cells. Okay, so real quick here, let's see. Insulin secretion in patients with manifest diabetes tend to disappear months or decades after diagnosis, a clear sign that there is a gradual loss of pancreatic cell function and cells. Okay, so half of the people in the study, this 30-year study, actually had a dramatic decline, and half did not. Half actually might have had a higher production of insulin, meaning that there's different factors that are influencing this, and we need to understand what those are. Okay, so the factors that damage or destroy beta cells include metabolic factors. High blood sugar all by itself can be, we call it glucose toxicity. So yes, we want to try to get that blood sugar down, but we need to do it properly. So the lipotoxicity, eating the wrong type of fats and the too much fat, all by itself can cause damage to the pancreas. The hypoxia, low oxygenation that we've been talking about. In order, you have to optimize circulation. You have to optimize perfusion. You got to get more oxygen to the tissues, because if you don't, that damages beta cell as well. We got the pharmaceutical approaches, the antimicrobial medications, some of them, SSRIs, okay, damage beta cells. Okay, so we got to look, are there better alternatives that don't damage the pancreas for those conditions? The basically environmental toxins, various poisons in the environment, and we could talk for hours about that. I do all kinds of pesticide testing, mycotoxin testing on my patients, and that's a big issue. That's one of the causes, reported, well-documented research causing damage to the beta cells. Mold toxins dramatically cause damage to an atrophy of beta cells. Pesticides and so forth. Infections are a big cause of beta cell dysfunction, as they are a big cause of hippocampal cell destruction as well. So we need to address those. And then we have infections, inflammation, autoimmunity, viral factors, all kinds of viral factors. You know, the Coxsackie virus is one of the causes of type 1 diabetes. Okay, but it's also very damaging to the brain. All kinds of viruses, bacteria, etc., really can be significantly damaging to the brain, especially if there's a dysfunction of the blood-brain barrier that allows that to get in. So that's why if you have a sinus infection or chronic sinus infections, or if you have even a respiratory infection that starts out in the nasal passages and the sinuses, how close is that to the blood-brain barrier? How likely is that infection going to go viremic across the blood-brain barrier and infect the brain? Very likely if you don't treat it right away. So that's why yesterday I emphasized treat infections early, aggressively, and as naturally as possible, and using strategies like iodine, nebulizing iodine, will destroy all those viruses before they can break through, meaning break through the blood-brain barrier, or break through into the blood and go viremic and affect the pancreas and other organs as well. So that's a really critical concept to be aware of. Okay, so I'm mainly trying to give you an understanding of why this is so important, so that you can take that handout, that 11-page handout that I gave you, to be able to, in fact, that's right here. Okay, so you know, we could go all afternoon on this talk alone, but we won't. We're going to be done here in a second. So I just want to draw your attention to this handout. The reason it says 2-hour glucose tolerance test on the top is because I developed this. I need to change that. I developed this handout initially for the group in Dubai. And they actually, you know, everything is very highly regulated in Dubai. I don't know if you've ever heard that. Okay. And so they literally can't get a 4-hour glucose tolerance test. They just won't do it. Okay. You just can't, you can't pay for it. It's just not available. Okay. And so rather than trying to change the system, let's just work with the system. Let's just at least do a 2-hour. Okay. But again, I prefer a 4-hour. Why? Because we talked about the importance of hypoglycemia. In 1996, Dr. Brenniger and myself were asked to work with the governor of Guam to head up the task force for the prevention of the diabetes on Guam and Micronesia. And this was a brilliant political move by the then governor, who basically we were part of his his campaign, inadvertently, because he knew that the health care was a major concern among the Guamanians, who had a 5-fold increased risk of premature death from diabetes compared to those of us on the U.S. mainland. It was bad enough here, it was really bad in Guam. Okay, and so he basically campaigned on several platforms. One of them is, we're going to prevent diabetes on Guam. I remember I was having lunch with a ER physician from Laguna Beach, who was there on Guam doing some workshops on contract. And I don't know how we met. We met hiking or something, and he said, hey, let me take you out to lunch, to Thai food. So I said, sure. So he was really kind of a really interesting guy who had a great sense of humor. And he said, man, this is funny. I was reading the paper this morning, and I saw that there was this task force on Guam talking about prevention of diabetes, and they have this whole document they worked up, and they're talking about preventing diabetes, and everybody knows you can't prevent diabetes. And so I just let him talk, because we were kind of friends. I just let him talk for a while, and then say, hey, John, hey, by the way, I'm the author of that document. Okay, I was the primary author. And he goes like, whoa, okay. And he says like, okay, I guess all the ER docs can learn something too. And so we actually developed a friendship, and every time I would go back to Loma Linda in the summer on furlough, I'd actually look him up in Laguna Beach, and we'd have a meal together. And it was a really neat guy. But so people that are open-minded are open to new information that makes sense, right? And so the whole idea was back in 1996, this is before prediabetes was a diagnosable entity. It was 1997 when this consensus panel got together of scientists and physicians and said, hey, we got to be able to reverse that. We can't prevent complications if we're not diagnosing diabetes until after complications are already beginning, right? So that's why they changed the parameters of diabetes. And the first 5 stages of hyperglycemia were developed for that task force. That's where that came from. It was published with CDC grant funds by the Department of Public Health in Guam specifically. So the CDC actually came out. They're going like, "Wow, this is really interesting. We need more information on this." Well, since that time, we expanded that to include 5 stages of high blood sugar and diabetes. This is a great clinical model to work from. It's not technically peer-reviewed. So what? Okay, so the new approach in learning things in medicine is not peer-reviewed journals anymore. It's listening to people that know what they're talking about. I mean, you go on YouTube and watch the top scientists and doctors from Stanford, from MIT, from all that. Those are the guys you want to listen to because they're uncensored. They say what they believe based on vast experience. Those are the people I listen to. Doesn't mean I agree with everything they say, but I'm much more likely to agree with them than some consensus panel, right? So, because of the politics involved. I presented this first 5 stages at an international conference in 1997, and the head endocrinologist at Kaiser, Orange County, came up to me and said, "Wes, could I use this at Kaiser?" I said, "Absolutely. This is CDC-funded research, right?" And so he took it to Kaiser, and a year later, we're speaking at another conference. And he came up to me and he said, "Wes, I took this to my endocrinologist at Kaiser and they loved it. It's not only a great clinical model, but you can use this to educate your patients where they are on the spectrum of hyperglycemia or insulin resistance. Looking at A1C, 1 hour, and 2 hour glucose. So use this, please." So it's a great clinical model to help people really see where they are at and to show incremental improvements over time. So it's not just whether you have it or you don't, but are you getting better? And are there other things that we can do to add to the mix to even get better? So use this model. It's a really effective model. I've been using it for many, many years. What's the most important step in addressing blood sugars? Test them. There's nothing more valuable than knowing what's coming out of your own body. Whoa, I had no idea I had this problem. Okay, so my encouragement to you is to take advantage of this handout. Okay, and this handout cell dysfunction. Oh. So where are you on the continuum of insulin resistance and beta cell dysfunction? So that's the first, get a baseline. And clearly educate your patient or yourself as to the relationship between how much insulin you're producing and how much blood sugar you have at that point in time. There's multiple different categories that are clearly outlined in that handout. Okay, and then the next, ideally, you want to do the glucose tolerance test just to be able to evaluate this properly. Okay, but then you encourage, this is what I do with patients all the time. I encourage them, says, based on knowing that you tend to have both high and sometimes low blood sugars, depending on what part of the day, you want to ideally just with your own money get yourself a continuous glucose monitor. Dexcom, which is the most accurate of all, as far as I know, it's the most accurate continuous glucose monitor, and there's a new Dexcom 7 that actually measures really high sugars and also really low blood sugars, all the way down to 40, I believe, and below 40, it just says below 40. But that company now has come up with an over-the-counter version of the continuous glucose monitor that does not require a prescription, and you can buy it yourself. It's called Stelo. And I'm encouraging people, if they just don't want to ask their doctor for a prescription, says you do not qualify insurance-wise for a Dexcom 7, which is the most accurate one. But you can ask your doctor for a prescription, understanding that it's not going to be covered by insurance. Now, if you're in an HMO, that makes it tough because there's kind of policies that for HMO doctors, this may be different in certain situations, but in my past experience, if you're an HMO patient, you can't get a prescription from unless it's going to be covered by the HMO contract. And so in other words, sometimes you have to go out to a different doctor that's not your regular doctor, and just say, I want a prescription for a Dexcom 7. And then you don't have to use it all the time. Just you want to use it for 2 weeks. Just see where you're at. So the biofeedback that you get from wearing a constant monitor is amazing, because it'll show you problems that you never dreamt you had. You had no idea, okay, until you start measuring. And all kinds of people have super high blood sugars right after eating. Half hour, 45 minutes, 1 hour, peaks. Boy, again, above 200. That's not good for anybody. We don't even want our diabetics to be that high. But how many diabetics do you know ever check their 1 hour blood sugars? Hardly any. Okay, so most of the time it's just a fasting blood sugar and maybe a pre-meal blood sugar so you can adjust insulin. But that doesn't tell you anything really about the impact of the meal you just had. So how are you going to make good decisions about whether that's a healthy meal for you unless you check your after-meal blood sugars? You're not. You're missing out that opportunity to make good decisions. And so the more data you get, the more power you have, the more control, the more mastery you have over that situation. So check your blood sugar. So the first thing I tell patients is, I want you to either use a finger stick method, okay, and always do the side of the finger, not the tip. The tip of the finger is where all the tactile sensation is, where all the nerves are. Okay, the sides of the fingers have very few nerves, so you're much better off doing the sides of your fingers, plus you got 2 sides to each finger, not just 1 tip. Okay, so you can always do it the old-fashioned way, but I recommend just get yourself one of those 2 options. The Dexcom 7 prescription, you pay for it yourself, okay, or the Stelo over-the-counter version. Now, then the first thing you do is I say, go home and do what you normally do. Don't change anything. Let's see what happens to your blood sugars based on what you normally do. You don't start a healthy program, then start checking. You totally misunderstand what's going on if you do that. So I say, go ahead and have some party foods. Go ahead and splurge. Do whatever you would normally do under different situations, birthday parties, Christmas, Thanksgiving. Go for it. Keep a notation of what you ate and what happened to your blood sugars. And that blows people away. That's why I had no idea that my blood sugars went up. A diabetic would say, I had no idea my blood sugars were going 350, 400 after meals. Before meals are not that bad. I was told I was in reasonable control. Remember, that is bad for everything, including the brain. Okay, so that's the first step. For a couple of days, just do whatever, party foods. See what happens under normal and party situations. And then the first thing you change is not your diet, it's exercise. Not because exercise is more important than diet. It's not, by far. Okay, but exercise, I want people to understand the power, the impact of postprandial exercise, immediate after finishing a meal exercise. And so we learned at the Guam Clinic Wellness Center, we would exercise patients right after a meal. We'd check them before the meal, okay, and we check them after the meal with and without exercise. And on average, okay, this is really important, on average, you lower the blood sugars between 1 to 3 points for every minute that you engage in postprandial exercise, after meal exercise. And how long do you wait after eating to do light to moderate exercise? Because there's a big cultural issue in certain countries. Don't exercise after eating. It's really bad for you. Now, is there some truth to that? Yes, there's some truth to that. What is the one form of exercise you don't want to do fairly soon after eating? Swimming. Why? Swimming is actually really good for you after exercise, but the change in temperature and the cooling of the skin causes blood to flow away from the muscles, okay, and you're more likely to get cramping. So there was a patient in Guam that was swimming at Family Beach after a picnic, and she cramped up and drowned in 3 feet of water. Okay, you can drown in a lot less than that if you're really cramped up. You just can't control it. And she drowned. So that's why you don't want to necessarily go swimming, okay, right after eating. Okay, but the goal here is immediately after finishing that meal, you want to push away from the table, and I tell ladies that means before you clean up the kitchen too. And if you and your husband have issues about that, just make sure he helps you clean up the kitchen after you go walking. Okay, so we want to kind of bring closure to that meal and clean up. Okay, but that every minute you wait, your blood sugar is going up. Your blood sugar is already going up because you've been eating. And so you want to immediately intervene on that rise of blood sugar by doing some light to moderate, not get sweaty exercise. That's a totally different type of exercise. I'm talking about just light to moderate, feel good exercise. You're not breathing hard. You're just taking deep breaths. You're enjoying it. It's kind of up to a lightly brisk exercise. Every minute that you do it, your blood sugar drops 1 to 3 points. So if you have a diabetic and they're really eager to get their blood sugars under control, and they're at stage 7 high blood sugar on the chart, and you want to show them the power of after meal exercise, you say before you change anything with regard to your diet, eat the same meals that you did before, where you have measurement of blood sugars at 1 and 2 hours after the beginning of the meal, and then what you do is you say, okay, just keep eating the same food, but now you add exercise, and look at the differential. And that differential is powerful. It's dramatic. And so if you have somebody at stage 5, 6, 7 high blood sugars in the early diabetic range, they can actually lower their blood sugars up to 100 points at the 1 hour, 2 hour comparison compared to not exercising with that same meal if they walk about 30 minutes after that meal. So I just went out. It wasn't hard. I actually enjoyed it. I didn't feel like exercising, but I got out there, fresh air, sunshine. I felt good. I was talking with my walking partner. It was really a good experience. And I checked my blood sugar. And compared to the last 2 days of eating the same foods without exercise, I'm now doing like a 80, 70, 80, 90, 100 points better. That's huge. You think that that person is just a little bit more motivated now to do that again? What if they had done that exercise after the meal but not checked? Oh, yeah, I felt better, but not that critical. We, humanly speaking, can't really conceive of how powerful that really is unless we measure. So take advantage of that. Okay, and then what's the next step? And that's part of your steps. The next step is in addition to after meal exercise, you now start adjusting your diet according to all the information in that handout. You're going plant strong. You're doing lots of non-starchy vegetables, greens, and colorful vegetables. The colors, the pigments of which are actually what changes epigenetic expression of the genes. Okay? So it's very, very powerful. And you start experiencing, wow, when I eat this, now I'm getting another 10, 20, 30 point improvement in my blood sugars. Okay? And now you're getting even more motivated and excited. Wow, I was told that once a diabetic, always a diabetic. You're going to be on this medication for the rest of your life. And now you realize, hey, that is not actually true. It's never been true, but I actually believed it was true, but now I don't anymore because I'm seeing the evidence with my own eyes, with blood that's coming out of my own blood, with blood sugars that are evaluating myself. This is powerful. And so little by little, you're able to optimize your diet more and more and more, and you realize, and this is where one of the controversies comes in. I remember when I first started training in lifestyle medicine, one of my mentors was Dr. John McDougall. I love the man, right? When I was president of the Alumni Association at the School of Public Health, which meant I got to pick all the speakers for the yearly conference, I picked him because I used his book, McDougall's Medicine, was my first textbook when I was working at the Loma Linda Faculty Medical Group. There was very little protocols and information on lifestyle medicine at the time, but I had his book, and I followed his book. Great protocols. But one of the things that I initially believed, and that Dr. McDougall was kind of promoting, is as long as you're plant-based, you can eat all you want. In other words, he even talks about it, the starch solution, right? Eat all the starch you want. If you're diabetic, that's not true. Okay, now, again, I love Dr. John McDougall, and I would never debate him on this topic. Because even though I'm right, I would lose the debate. I know. I've seen him debate other people in conferences, and I go like, man, I'm glad I'm not arguing with him. A great guy. But so, there's partly because he in his clinical practice didn't actually follow this initial protocol of testing after meals. He would wait and do the A1C. And yeah, you can eat a lot of starch and still get an improvement in the A1C, but it's not going to be nearly as much. Why? Because the hemoglobin A1C is an average of how many months of glycosylation? 120 days, so 3-4 months, right? So it's an average, but what is the single most greatest predictor of increasing your hemoglobin A1C, even after a couple weeks? Your postprandial blood sugar. So you can have great before meal blood sugars, but if your blood sugars shoot up for 1 hour or 2 hours and then come right back down to normal or low, you're still getting that peak, and it's the peak that causes that caramelization, that glycosylation, that glazing of glucose irreversibly to proteins everywhere in your body, not just the hemoglobin that causes the hemoglobin A1C to go high, okay? But it happens in every protein of your body, and that is what we call AGEs. It's a great, clever acronym, Advanced Glycolytic End Products, and that's a major form of pathology. So the A1C test is not just an average of your blood sugars, it's actually a pathology test. Explain that to your patient. This is a pathology test. This is showing that you're irreversibly caramelizing glucose. So that's why it motivates people to lower your postprandial blood sugars, right? And if you do that aggressively, you can get drops in A1C within weeks a dramatic drops in hemoglobin A1C in just a couple weeks. That's exciting. Is that motivating to somebody? Very, very motivating. So if you start following more and more of the protocol and the steps, and I could have added another 20 steps to this that I clinically deal with patients when I'm dealing with them. But these are the most important fundamental strategies. And with that, we're going to end. Because otherwise, we would never end. Okay, so I think I didn't realize I went over time. But I know that many of you need to catch planes or need to get going, need to get on the road. So feel free to, I don't know if we need any housekeeping announcements at this time. I am willing to stay by to answer questions for about 20 minutes if you wish. I just want to make sure that Cindy has a chance to give any announcements that she has. And is my mic not working at all? Oh, battery went bad. Oh, well, hit me. Okay, so let me.
Is available at local. You can go.
All right, so she's asking, are these continuous glucose monitors available? They're available nationally, and you can just go on. You can just Google for Stelo, S-T-E-L-O, okay, and that's from Dexcom. It's the company that makes the prescription ones has now made this available to the public as well. So those are available to anybody, and you can get a one month patch for $99. Excuse me, a 2-week patch. It's a 2-week patch. So, okay, am I on now? Regular? Okay, so we'll give this over to Cindy.
So we have questions.
Oh, okay.
Somebody mentioned the 4-hour blood glucose test, but here's 2 hours, the 4 hours.
The only reason that I had 2 hours on this is because in Dubai, they didn't have a 4-hour test.
So 4 hour.
But anybody can order. This is there's a change recently occurred with LabCorp, where LabCorp you can't order a 4-hour test anymore. Like I've been ordering 4-hour tests with LabCorp since 1990, and all of a sudden, their computer said the lab techs are saying, "No, we don't know how to do that." Like what? So you have to order for LabCorp, what I order is a 3-hour glucose tolerance test, but it's called a glucose insulin response test. So they actually measure insulin at fasting, half hour, 1 hour, 1.5, 2 hours, and 3 hours. So it's a little bit more insulin than I want, but it's actually very cheap. So it's just more information. Okay, and then they measure glucose at those same time points. So it's a glucose insulin response test through LabCorp. Through Quest, and what I prefer is a 4-hour test, so I'm catching that potential low blood sugar at 4 hours. And by the way, you can have a low blood sugar at 3.5 hours, and it's back to normal at 4 hours. So you're not always catching hypoglycemia with a 4-hour test because you're waiting an hour between tests. So your blood sugar can crash and bounce back up. Why does it bounce back up? Because the adrenals are kicking in. And cortisol is telling the liver to dump glucose into the bloodstream. So that's why I tend to measure cortisol at the same time. So I'm getting a 3-dimensional model of that metabolic issue. So I'm more likely to catch the problem. But with Quest or with ultralabtest.com, which uses Quest, you can order a 4-hour test, and you can order a fasting 1 and 2 hour insulin, which is a 3-specimen insulin specified to fasting 1 and 2 hours. I'm going with the mic. Yes.
You mentioned a couple of times that estrogen dropping at menopause is a risk factor for cognitive decline. So is hormone replacement therapy at all an answer for that?
Yes, absolutely. And so now this is obviously very controversial with the Women's Health Study. The Women's Health Study was an amazingly well-done study The problem with it was not the study, but the way it was interpreted. Okay, and I'll kind of leave it at that. This whole idea that estrogen increased risk for heart disease and all these other cancers is actually not true. The problem was the progestins that were added at that time of medical history, and still today, a lot of these synthetic progesterones, which are not progesterone, they're progestins, which are horrible hormones, okay, which I would never advise progestins personally for anybody, at least for the purposes that I'm working on. And so I'm a big fan of bioidentical progesterone. I'm a big fan of bioidentical hormone therapy and replacement therapy. So it has to be done right. If it's done by somebody that actually understands the medical literature, okay, and had gotten past the initial bias of the way the women's health study was interpreted, then you're going to be good. And the bottom line is, especially for women who go through early menopause, okay, or go through surgical menopause with a oophorectomy and hysterectomy, those are really bad for the brain. And when you have an abrupt, dramatic drop in estrogen and progesterone, for that matter, that's really any hormone, it's bad for the brain. Those are the trophic factors. Okay, so yes, I absolutely recommend and refer my patients to doctors who are well researched in the area of bioidentical hormone replacement therapy appropriate, and that's really important for the brain. So I absolutely think it's an important step. Uh-oh. Yes, Dr. Emerson.
Yeah, I just wondered what the name of the test that patients can order themselves. What was? How
Okay,
did you
so
do that?
well, Ulta, ULTA. It's actually in my handout. Ulta Lab Tests, TESTS, ultalabtests.com. Okay, and so you can just Google Quest Labs and Ulta, and you'll see the website. And so ULTA. And so what it is an organization that it's a medical organization that has resident physicians that review every order. So any patient anywhere in the country can order any lab they want. So it's approved by the Ulta Lab Test physician, and then it is sent to the patient. And like our clinic, we have a contract with them so that we can help the patient. You know, one of the problems is knowing how to order and what to order. Okay, and so we actually help them order the test. And like you use professional co-op services, I've been using them for 15 years. And that professional co-op services is an organization that only works through physician clinics that or physician-associated clinics that allows you to order any lab you want through LabCorp. So in our clinic, we have that available plus the Ulta Lab Test option. So we yeah. And so did that answer your question? Yeah, we have doctor in the back. So just get Cindy's attention, because I go with where she goes.
So I have a couple questions. First of all, you mentioned that this handout had only 2 hours. Do you have another handout that has the other 4 hours that you normally go with?
Well, so the stages of hyperglycemia there that you see at the front page, that typically we only use the first 2 hours to establish stages of hyperglycemia.
Yes.
So I do not have. I've thought about this, that it would be actually worthwhile to create an additional column that looks at 3 and 4 hours. Here's the problem, though. The problem is how do we contrast or compare those to the diagnostic stages which are stage 3, pre-diabetes, stage 5, diabetes, right? How do we contrast? And there's really, it gets really muddy when you're looking at the 3 and the 4 hour. The benefit of understanding the 3 and 4 hour from a hyperglycemia standpoint is, do you have persistent hyperglycemia, which means that either your insulin resistance continues to be a problem and the pancreas is not able to make enough insulin to compensate the insulin resistance at that time point. So if your blood sugars come down really good at the 3 hour, which usually happens, by the way, most diabetics don't have a high 3 hour blood sugar, but some do. And that means they're more resistant and they're they have greater degree of pancreatic failure. If you can help me figure out how to put that in and not confuse the issue, and maybe we can add a different column to explain that. Maybe that'll be the best option.
I would like that.
Yeah, okay.
The second question I had, and I have a total of 3. The second question is, you gave 3 of the steps that you normally use, and you have 20 extra. How do I get a hold of those 20 extra steps that you carry?
It's on the handout.
Oh, all 20 of those steps that you would
It's, I think 21, I believe.
Okay, and this
did it not
same
get
handout?
on there? What?
Oh, okay, I didn't see it.
Huh?
And the last question was the Stello versus the
Oh,
G7.
they're not numbered?
It says step through 5, but then you go on with.
No, there's 8.
No, I know. But he's looking at just this number.
Oh, okay. So yeah, maybe I need to rework. It's a little confusing the way I initially set it up. But so what I wanted to do is add, what are the strategies beyond the initial intervention strategy with the patient? Here's how you get started so you know where you're at to get a
Yes.
good baseline.
Yes.
And you realize how important the after-meal blood sugar is, and now that starts helping you make better decisions. But then you have all these other strategies where you're incorporating both natural and simple remedies to optimize further.
And that's in here
Yes.
already? Okay, super.
Yes.
The last question was the comparison of the Stello to the G7. The parameters at which they monitor sugar, both high and low. Do you know those differences?
For which one?
The Stello and the G7.
For Stello, it's actually 70 to 200.
So it doesn't go below 70.
Yeah, that's the biggest reason I suggest. There's 2 reasons I suggest that you at least attempt to get a prescription for the Dexcom 7, which is more expensive, but it's far more accurate. Number one, you're more likely to get a reliable, reproducible number, and which isn't always easy with blood sugars, as you know. But you're also more likely to pick up the low blood sugars, which is a big concern of mine.
Yeah.
That you're not going to see that on the Stella. It's just going to say under 70. Well, there's a big difference between 65 and 50, and there's an even bigger difference between 50 and 40. Okay, and so the Dexcom 7 goes down to 40, and that's very valuable information in my mind. But if you just want to get a Stella just to start tracking, it's going to give you a lot of data to get you motivated, and that's the whole point.
The concern that I wonder about with the Stella, because I've seen this on the Libre, is that when you go below a certain level, the machine auto-tests and then shuts down, and it says, we will no longer give you any more data for the rest of the life of the device.
Oh.
Because it was too low, and so it automatically defaulted.
That's not good. Okay, so another reason to go with the Dexcom 7 if we can. Yeah. Can we get the mic in the back on? Oh. Oh. We're just draining energy out of the batteries.
If you can't get a Dexcom 7 covered, you can get a 2-week trial for concerns of hypoglycemia or large variations in blood sugars. You can get a 2-week trial covered to get that data, even if it's not covered long term.
That's nice. That's nice. So thank you, Dr. Sarah. Okay, I didn't realize that. That's great. I came to learn myself. All right, yes.
I just had a question about, you mentioned on Friday, I think, about different supplements that might help the people with Alzheimer's disease. You mentioned about like ginkgo biloba and then alpha lipoic acid. Do you have a list of those type of things and what doses?
There's a whole list. Dr. Emerson started addressing some of the supplements that there's a lot. My book actually has quite a significant list in it. I usually don't talk a lot about supplements when I'm in conferences because I want us to make sure we get the fundamentals down. But let me say this. I did mention yesterday that I've seen multiple patients decompensate after after they were told by their primary doctor or by a family member, this is crazy, you shouldn't be on this, it's a waste of money, and they literally decompensate after stopping the supplements. So we have this mindset that supplements are like, maybe a little bit of benefit, okay, but actually, especially in those of us that have low resiliency, low hippocampal resiliency, and a greater problem, supplements actually make a big difference. They actually fill in a significant gap that is not easy to fill in otherwise. And so when we're dealing with this, we're trying to do everything possible to fix those 32 holes in the ceiling. And supplements are a very easy, simple remedy that everybody can do. It's a cost factor, which is very real, okay? But everything's a cost factor, and when you contrast it to memory care facility costs, there's no comparison at all. So with that said, I will actually prioritize. When I do genetic testing, we're actually learning what specific nutrients, individual nutrients, are needed at extra levels to compensate for the enzymatic defect caused by the mutation, right? So we know biochemically what enzyme is involved with that mutation and what the cofactors are that influence the cofactor function, and they just need more of those cofactors now because of the mutation. So there's all kinds of good research on the metabolic tune-up and others talking about the importance of optimizing cofactor levels based on genetics and et cetera. And that requires more of certain nutrients, which starts, as Dr. Emerson pointed out, with lots of nutrient-rich foods. Like Dr. Joe Furman says, a nutritarian diet, by definition, is a diet that's loaded with nutrients, but not necessarily loaded with calories. And so it's not about necessarily how many calories you consume, but are you getting more nutrients with those calories, or are those empty calories? Or are we in a condition of hypercaloric malnutrition? That's what most of the U.S. is involved. We have hypercaloric malnutrition. And so we need to fix that part of the two pillars of health and healing, right? We add to that appropriate nutrients. So real quickly, when I first see a patient who has any concern about cognitive decline, either family history or subjective cognitive decline or early parts of MCI or Alzheimer's, I always say, here's 5 things you can start right away. Even before I need any tests. Those 5 things are CDP choline, 500 milligrams twice a day. All kinds of research on this. By the way, when I first learned about CDP choline, one of my patient's mother, actually she was my patient too, in Fallbrook, California, asked Dr. Nedley what else they could do, and he said CDP choline. And so I actually, this was 15 years ago, I hadn't even heard of CDP choline. So I looked it up, and I go like, how did I not know this already? Okay, it was all kinds of research on it, and so I immediately started recommending CDP choline. It's actually top of my list. 500 milligrams twice a day, CDP choline.